right, there's a chat box. Okay, so if you are if you want to have to do a comment or make a question, please write something on that chat box just for me to know that you are that you want to say something. Okay, we are not that many on the call, but it makes my job easier. Yeah, so thanks, Elizabeth. So I think we all know the diabetes situation in Europe. This is the latest data from the IDF Atlas. Of course, if you look at Europe, the darker places are the places where we have the higher prevalence. My own country, Portugal, is always very dark, as you can see, like Turkey, for instance. So, but what is more frightening is the rise of diabetes in Europe. Elizabeth, can you please put the next slide on? Which, if you can see here, the estimations for 2045, you can see a rise on the prevalence. And that's what is for me more frightening, is that we are not yet on the situation where the curve is bending. So that is why so much needed that you as young advocates to do more and more. Elizabeth, please. Okay. So today we are going to talk about the situation in 3 different countries: Ukraine, Italy, and Sweden. So we have 3 different parts of Europe: the Nordic countries, Sweden, the south part of Europe, Lucca in Italy, and the eastern part, Svetlana. So we are going to use these 3 different examples to trigger the discussion. But when it comes to healthcare expenditure, and this is from the Diabetes Atlas, you can see here a huge difference on the bottom of the slide regarding the healthcare expenditure per person with diabetes. It goes from Norway to Armenia, Kyrgyzstan, for instance. And if you look at these numbers, you can see the difference there are between countries. So there are huge health inequalities around Europe and within countries as well. I think most of you have participated on IDF Europe youth camps. It's quite interesting when we put 24 youngsters in the same room talking about diabetes and their situations in their own countries. People don't realize the situation of diabetes in other countries. I do remember quite clearly people from the Nordic countries to be amazed with the difficulties that people from the eastern part of Europe are having at this moment in time. So Elizabeth, please, can you put the next slide on? So at IDF Europe, we have a few publications. These are 2 examples of 2 publications. On the right-hand side, we have Diabetes in Europe. So if you want to have some data on diabetes, you can use that. Both publications can be downloaded from the website. And on the left-hand side, you can see the Access publication, which goes back to 2013. So I will only give you a smell of it. Elizabeth, please, the next slide. So we have tried, again, the next one. This is the link to download the publication. So we have scanned 47 different countries in Europe to access to the availability, the accessibility, and the affordability of the diabetes access to treatment. And again, we have found the same difference between countries when it comes to total spending on health. Can you please pass the slide, Elizabeth, the next one, just to save some time. So we do found out huge health inequalities between countries. Accessibility is one of the most dramatic problems when it comes to access to diabetes care, because the health systems of different countries are very, very different. Okay, can you put the next slide on, Elizabeth, please, just to save some time. So when a person with diabetes lives in a specific country, the treatments, the insulin, the oral pills, the technology is affordable depending on the health system of that country, and we have totally different health systems. And in some countries, within the country, depending on the region where you are living in, you can find huge differences as well. Like I think in Italy, like in Spain. So that's something that IDF Europe is trying to fight, of course, and but it's not easy because it depends on prices, reimbursement. So it's something that it's very easy to tackle. Elizabeth, can you please move on? Okay, so that was my short introduction. Now I'm going to pass to the three speakers, which will be Svetlana first talking about Ukraine, and then Luca talking about Italy, and Kaisa talking about the situation in Sweden. Svetlana, please, can you?
Okay, thank you. I'm going to talk about the access to diabetes care in Ukraine. As it was told, we have the low access, and it is caused by several factors and by several conditions that are in Ukraine. So please, the next slide, put on the next slide. So there are over 1 million people who have diabetes in Ukraine, and namely 10% of them have type 1 diabetes and 90% have type 2 diabetes. It's not as much as that, but in some other countries there are more people having diabetes, but for Ukraine it's really a big amount of people. So please put on the next slide. The insulin, what about the insulin, and if it's paid totally or partially? There are some conditions and categories of people who get insulin for free. The first category is pupils and students. So they get insulin for free without any pain, and they always have an opportunity to get it. And the next category is people who have who were diagnosed after 18, and but in case of treatment for at least 1 year, the HbA1c level should be less than 7.5. Then they get insulin for free, but if the level of HbA1c is higher than 7.5, you have to pay some amount of money, but it depends on the region of Ukraine. In most cases it's €1, or it can be more, maybe a half. They should pay half. So please, the next slide. So if this, what about test strips? People have to buy test strips, and a box of 50 test strips costs 9.5 to 11 euros. It's as for me, it's not very cheap. Because the salary in Ukraine is not as big in other countries, and I spent around 152 euros per year. So the next slide. And what about insulin pumps? This situation about insulin pumps is very bad in Ukraine, if I can say so, because they are not paid by the government at all. People should buy them themselves, and they are very expensive in Ukraine, and only some people can buy them. As for me, I know only a few people who have insulin pumps, and I haven't bought it because it's really expensive. So, and how is it difficult to get insulin pump? It's I put 4 because it's easy to get it, but they are expensive, so not everyone could buy it. So could you put on the next slide? So CGM devices. CGM devices are available, and but again they cost too much, and a box of 4 costs 150 euros. It's for Ukrainian people, it's very expensive. And please put on the next slide. Oh, sorry, it's at the end, but I want to add that CGM devices available, they cost too much. And what about needles? Needles for pens, they are not paid for people. People should buy them. And as for me, I spend 70, 80 euros per year for needles for my insulin pen. So if I think that's all about situation in Ukraine. As you see, it's not too easy to live with diabetes here, because we should buy almost everything ourselves. But there is one thing that when I was a student, the government used to pay me a kind of financial assistance in the amount of 43 euros every month, and then I had an opportunity to buy everything with this money. But now, as I have finished the university, I have to buy everything myself with my money. So I think that's all. Thank you for attention.
Thank you, Svetlana. Now, Luca.
I've seen that Kesa ask a question. I think you can answer directly before my presentation, and it's a really short answer. What is the average salary in Ukraine?
212 euros.
Okay. Thank you. So it's my
Thank you for the question.
Do I have to start? About the number of people living with diabetes in Italy, we are shown by the first slide. We have around 300,000 of type 1 and around 3.5 million for type 2. But I have to say that these data are of 2015, if I'm not wrong. It was very difficult to find the exact number, the correct number, the updated number. So more or less will be a little bit more, but exactly, I don't know. I even checked on the ISTAT, which is the National Agency for Statistics, and they had data of 2015, and so it was really strange. Maybe this can be a problem, as there are no many data about expenditures or the number of people living with diabetes. Talking about the access to care for diabetes, as João before say, we have our national health service is based on the principle of subsidiarity. So the state has to define the minimum standard, which are quite high, if I have to say. And then the region has to respect those standards, and if the region wants, can give more. So usually they depends by, of course, the region, and if we have to speak easy, in the north part, usually the standards are higher, and in the south they are lower. But at the same time, there are some exceptions, as for example, Campania, which is the region of Naples, which is the first region in the giving of insulin pumps. Sorry. So our system, well, the health system is quite complex, as is a true system in the meaning that we have different bodies that are connected, and even if we have this minimum standard, not all the time the bodies or the region comply with them, and at the same time there can be present a little bit some differences even between two really close cities, because of the doctor or because of the rules in a specific hospitals. So, for example, a lot of people from Reggio, which is a city which is like 30 minutes from my city, Parma. There are a lot of people that come from Reggio to Parma to receive treatment, because we have higher distribution of supplies. So going to the next slide, we have some direct answer to the question. Can we? Okay. Yeah. No, before exactly. So as to fix this problem, this difference between region, 2 years ago has been set up the National Plan for Diabetic Disease. I don't really like the name diabetic disease, but that's the name. It's a manual, if we want to say that is aimed to make more homogeneous across regions the services, so as the expenditures, and it's quite working. As I said, for example, before, the Campania, the Naples region is improving, and so as others. But I mean, one thing is creating a law, another thing is to make it real, a concrete action. So moving to the next slide, we have the direct answer. Yeah. As you have probably understood, we don't have to pay insulin, and the only difference, depending on the region, is where you have to get the insulin. So in my region, Emilia-Romagna, which is the one of Bologna, just to be more clear, we just have to go to the hospital, and we receive directly the insulin, so as the needles and the tools for the insulin pump and so on. In another region, you have to go to the pharmacy, and well, it depends, but I mean, it's just a change of place, so it's not a really a big deal. And differently from other countries, we don't have to pay and then we receive reimbursement, but we directly get the insulin or the other supplies. And then the other slide is, yeah, okay, it's completely free. The test strips are free, but there are some exceptions depending on the patient. In the meaning that for people who has to take insulin injection, test strips are between 100 and 250 each month. And for those who don't have to take insulin injection, so type 2, I would say, they are like between 0 and 50 every 3 months. But if someone wants to buy extra strips, they can, but they are quite cheap. So, and usually, I mean, 200 strips for a month, I think they're more or less quite enough. And yeah, so we actually don't pay anything for the strips or for the insulin. Also, the insulin pumps are fully paid by the government. For us, there is a first meeting. We have to speak with our doctor that we are interested in having an insulin pump. Then our doctor presents us the main different how you say the different kind of insulin pumps, the different features, and then we discussing with them with the doctor. Sorry, we decide which one would be the most interesting, depending by our activities during the day and so on. And after we had some meetings with a representative of the pharmaceutical, and then we had a trial of 1 month. And if you are happy with that kind of insulin pump, you can continue and you will receive yours, and you can have all the supplies each 2-3 months. You just have to order them like 2 weeks before then when you're going to finish, and you don't have to pay anything. You just go to the pharmacy or to the hospital and you get your supplies. And so about the difficulty in getting insulin, I would say that is between 4 and 3, depending by the region, because as I said before, we have minimum standards, but at the same time, well, we have different standards, but the average is quite good, as I said, with the Campania example. So the worst region, yes, is Sardinia and Sicily, the 2 islands. And I think that's all about the insulin pumps. Yeah, okay. Yeah, the CGM devices are available and are fully reimbursed, except for the Freestyle Libre. In some region, you can have it for free, in others you can't. But now, even this particular element is improving. As for example, last week in Emilia-Romagna has been sent a note to the hospitals informing them that also the Freestyle Libre will be paid. So, well, everything is paid more or less. And all the slides were about the job. There was one about the job, I think. The next slide, sorry. Yeah, this is about the checkups. Actually, we don't have to pay neither for the checkups or particular checkups related to diabetes, of course. For the others, we have to pay. A particular element is that when you are younger than 18, you don't have to pay anything. And if you do a request, you will get more or less 200 euros each month until you will be older than 18. Moreover, when you are a kid or a teenage, your parents ask for a specific law. Your parents will be able to leave their office to go to the school and make injection. So it's a special permission, and I think that because all of these features, we can just be happy with our situation in Italy. The only thing is that we cannot be enrolled in the army. Talking about the jobs, about the psychological support. We, depending by the region, I know it's a really common answer for me, but it's the way it is in Italy. As psychology support is, as we would say, higher service. Maybe it's not a direct one like insulin or needles. It depends by the region, but often there are many associations that works for that. And for example, in Parma, my association pay for a psychological support for the kids and teenagers that the diabetologists decide that probably need an extra help. And yes, glucagon is available for free. So I think that's all.
Okay. Good. Sorry, before going to the Swedish situation, JS question on if there is a cap on the budget expenditure. Do you know, Luca?
Sorry?
If there is a, Jay has put a question on the chat box asking if there is a cap on the budget expenditure, meaning that there is.
Oh, sorry.
Do you know what is a cap on the budget?
I don't know expenditure.
No? Well, Jay can ask lively, but if there is a maximum amount of money that the government reimbursed or pay for a specific thing, meaning, for instance, in Portugal?
Well, yes and no. More or less 20, 30 years ago, a politician set up a really strong law for diabetes, and because of that law, we have all the guarantees we need. I don't remember the number of the law, of course, but the main point is that because of this law, we have all these particular elevated standard, and everything that came after. So, for example, the insulin pump, needles, all the new technologies over time are given because of this original law. So no, I don't know if there is.
I don't think there is.
The point is that, of course, each hospital or doctor has a maximum, because they cannot give you like 300 strips for a week. I mean, it has to be has to be decided by the doctor who is helping you with your diabetes management, and every decision you take has to be more or less motivated by your specific situation. So there is the example of before about the people who don't have to take insulin injection. They don't need 250 strips, but just between 0 and 50.
Grazie, Luca. Kaisa, can you talk about your own experience in Sweden?
Yeah, absolutely. Sweden is an example of a high access country, but as I was saying yesterday in our discussions, in a lot of ways, Italy has a more generous system.
That was defined as a medium one.
Sorry, come again?
Italy was defined as a medium country.
Yeah, it's interesting. In Sweden, we have a population of 10 million, and we have around 50,000 people that have type 1 diabetes. 7,000 of them are children. Sweden has the second highest incidence of type 1 diabetes in the world after Finland, so it's a quite high percentage. The figure has fallen out, but the number of people with type 2 is around 350, 400,000 people, depending on the source you use. I should also say that the average income in Sweden, it varies depending on again, the source you use, but it's between 2,300 and 3,200, so it varies. As far as insulin goes, it's completely free for everyone with all types of diabetes, type 1, type 2, and everything in between. It's on a list of medications that that are considered particularly crucial. And as insulin is a medicine necessary for life, it's on that list. Much actually thanks to the efforts of the Swedish Diabetes Association. It's been debated several times whether insulin should be taken off that list, but the Diabetes Association has advocated for it to be kept on the list, which we're very happy and grateful for. Could I have the next slide, please? As far as test strips goes, they are completely free for everyone with type 1 diabetes, and they're also unlimited in number, meaning that I can get any number that I need. For people with type 2 diabetes, it varies, like Luca mentioned, depending on whether you're on insulin treatment, tablets, etc., etc. And naturally, those who are not on insulin have a much more restricted access. It's been debated. The national guidelines have been interpreted in a very restrictive way in a lot of regions, meaning that people with type 2 don't get access to test strips. And for those who do have to pay for them for their own test strips, a box is about 10 to 15 euros. As I have type 1 diabetes, I don't personally spend any money on test strips. When it comes to insulin pumps, they are completely paid for by the government. And I'll add to what Luca was saying about it varying between the regions. In Sweden, healthcare is also regionalized, meaning that it's the counties or the county councils that decide on the budgets for healthcare. So it varies quite a lot what kind of insulin pumps are available and who gets them. So there are quite a lot of differences in terms of access. It varies a lot depending on your age. It's much easier for children, obviously, to get insulin pumps in all of Sweden. And it also depends on your HbA1c. And it is the case, as in many other countries as well, quite interestingly, that the better HbA1c you have, the harder it is to get an insulin pump. But on average, I'd say it's about a 3 or a 4. And for people with type 2 diabetes, it's more or less impossible to get an insulin pump. And if you do get an insulin pump, the supplies are fully reimbursed. CGM devices are available and they are reimbursed. Not everyone gets access to them though, so some people pay for it themselves, especially Libras are popular to pay for themselves. One Libra sensor is about 50 euros, an Enlight sensor has the same price, and the Dexcom is about 70 euros. There are discussions in certain counties or certain regions about reimbursement for CGM devices and glucose monitor devices. And in one region, in one county in particular, this year they've started charging a fee for CGM devices and glucose monitor devices, which we feel is a step in the wrong direction. But it's also an interesting discussion whether that makes them more available to more people when you actually have to pay a small fee. Does that allow more people to actually have access to them, because it makes it cheaper for the hospital and counties. In terms of needles, they're paid for, no matter what kind of diabetes you have. As long as you have insulin, they're paid for. And as a result, I don't spend any money on needles. The cost of visiting a specialist varies, again, from country to country. And the price is around 20 to 40 euros per visit. But we have something called a high cost protection system, which means that within a 12-month period, you'll pay a maximum of 110 euros for your doctor's visits. Meaning that as soon as you get up to that amount, you pay nothing more for the rest of that year. And diabetes education, we don't have diabetes educators in Sweden, so the education usually happens in the hospital setting by a nurse or maybe a doctor, but most often a nurse. I should also mention that in Sweden, as of quite recently, 3 years back, there's been a change. So you're allowed to seek healthcare in any county you want, irrespective of whether you live in that county or not. So say that I'm not happy with the healthcare that I'm receiving in Stockholm, I'm allowed to go to Gothenburg and say, I would like an insulin pump, I would like a CGM, et cetera, if I know that they're more generous in giving patients access to that. And that's a part of a change that happened a few years ago, aiming to increase the rights of patients in Sweden, and that's irrespective of your diagnosis, so not only for diabetes. In terms of psychological support, it's something that is quite heavily debated in general, and for diabetes, it is quite difficult to get access to a psychologist or any kind of support. It's not impossible, but it's difficult. And if you do get referred to one, you still have to pay. And the same system applies to other specialists. So you pay a maximum of 110 euros per year. Could I have the next slide, please? Glucagon is available in our country, but it is not on that list I mentioned before of essential medicines. So you do have to pay for it yourself. There's a reduced cost though, so you don't pay the full cost of it. One kit costs about 20 to 30 euros. And the same as for doctors' visits, we do have a high cost protection system for medicines as well, where you will pay a maximum of 220 euros per year for your medications. Meaning that if you, after 3 months, have paid 220 euros, you pay nothing for the rest of that year. Yes, and in terms of professions, it's a lot of the classic ones that are unavailable in other countries as well, and it's the police force, air force, military, navy, and anything related to professional driving or being responsible for transportation of other people, including taxis, buses, trains, trucks, etc., etc. And I think that was the last slide, if I'm not mistaken. I should mention as well, if I can just say, something that we're very proud of in Sweden is our national registry. We have a national diabetes registry that is quite unique in the world. It's existed for 22 years, since 1996, and it has a large coverage. And in the primary healthcare, it has about I believe 92% coverage, and specialist care for type 1 diabetes, it's 98%. And you can find anything from how your hospital is performing in certain areas, the average A1Cs of a hospital or a region, every other kind of parameter you want. And a lot of research is actually based on the information available in the registry. So that's something we're very proud of. And there's also been recent additions to it that include more soft values, so to speak, such as how the patient is experiencing their health care or their own health. So that's something we're proud of.
The interesting part of if my memory is correct, is that it's not mandatory for the healthcare professionals to use it, but everyone uses it. Yeah. So this is a huge difference between Sweden and at least the south countries in Europe, which, if it's not mandatory, people tend not to use it, which is annoying from my point of view, but it is the truth. Yeah. Dimitri has put a very interesting question, and I was making notes about the same thing, about the linking access to new technologies, and in Ukraine, the price you have to pay for insulin on your HbA1c, on your control of diabetes, which in Sweden is the opposite way, if I get it right, meaning that in Sweden, if you have high HbA1c, you are more prone to get the insulin pump. I think the rationale is that you are not well controlled and you need something else to control your diabetes. But in Ukraine, if you have higher HbA1c, you have to pay more for your insulin. So it's a different way of seeing the same thing. So what do you think about this system of depending the access to insulin or access to technology based on your HbA1c? And Dimitri said that it's quite punitive for the people living with diabetes. So what do you think? And this is open. I mean, we are not that many in the call, so I will try not to make this very chaotic. But no matter what, it's as we are 10 or something, we can discuss among us. Starting with this, Jade, do you want to say something? You are listening, and we are seeing you in your car. So can you can share with us your situation in the UK and what is your opinion about making this link between your HbA1c and the access to treatment?
Yeah, hi. Thanks everybody for that as well. It was really helpful, and thank you, João, for moderating as well and for taking the time to be with us today as well. So, in the UK, it's kind of, it's hard to understand sometimes the decisions made at a central level and how they relate to how it relates to our experience on the ground, because we have a central national health service which is funded by taxation, people paying money into taxes, and then decisions about care are then left to local areas called clinical commissioning groups, which are groups of general practitioners who are left to make the decisions about what is purchased and what is actually provided at an on-the-ground level. And that comes with a budget. That is a fixed budget. And so as a provider, I'm a provider of healthcare as well as a type 1 person living with type 1 diabetes. I often am stuck between this decision between I have a limited budget, so I'm only able to provide a certain amount of care, but I want to provide everything for everybody. And so that becomes the difficulty in the UK, is that you have to find some way of rationing sensibly, and you're damned if you do, damned if you don't. If you ration in one direction, there is a group of people who say to you, oh, you're only providing things for the people that are good. And if you ration in the other direction, you say you're creating a negative incentive and making people give bad blood sugars in order to get the best care. So it's a very difficult situation that you sit between because of short-term budgets mainly, that people don't look towards what's the benefit in the long term of providing people with safe, stable, effective care that's evidence-based. And I guess that's my question to you, Kaiser, is does the government and does the central system use the data that they have in the repository to make good planning decisions? Because that's not what the government does here, even though we have access to one of the largest healthcare data sets in the world in the UK.
Are you referring to the registry, if they use the information available there?
Yeah.
Yeah. Yes and no. Yes, they do. They do use that as a basis, but they also make decisions, in particularly in regards to the national guidelines that are very difficult to understand. Why certain actions are prioritized the way they are is not necessarily based on the data available or the experience of the healthcare professionals. So yes and no.
So look at the units. I think one of the things that you have mentioned is the lack of data. and good data to rely on decisions. So you see that even if you get good data, you cannot, sometimes the system, the healthcare system, do not rely on the data that they are collected. So it's not.
I'd say the political motive takes over from the data. So even if the data tells you one thing, the political imperative, the political motive is to have an efficient healthcare system in the 3-year or 4-year period while those people are in power. And that becomes the difficulty, is how do you create good data and good action from that data in a system where people's motives are very short term.
Yeah, exactly. Because, for example, in Italy, the 11–12% of the all health expenditures are for diabetes. But at the same time, of these 11–12%, the 90% of this percentage, so the 9 point something of the total, is for type 1 treatments. So all the other are for type 2 complication. Why don't they put more money for direct treatments of insulin needles, test strips, and so on? Because if they will do these, they will have a gaining just after 10, 15, 20 years. So they, as Jay said before, they look for the short term and improve the quality of the treatments. Needs too much time to something that will be good after 10–15 years. They wanted something that give them the chance, or a greater chance, to win the election. So why? I guess that's the point, I think.
My question to all of you, including Svetlana, because I realize you're still on the line, and I guess João, you may be really equipped to answer this question, is this is a really important problem for everybody who seems to be on the call, is what actions can we take as individuals to help affect change in that problem, or to help inform the people in power about that problem?
We can go one by one. Svetlana, do you have any?
Okay. What about actions that, for example, my association can do? We organize some meetings, some even I don't know, such as the World Diabetes Day. We invite many people to listen, to look, and to learn what is diabetes and what we can do. But still, there are many people who don't understand what is diabetes and what is it exactly. If it is an illness or maybe a style of life, as we sometimes say. I don't know exactly what can I do in Ukraine, because it's there is a lack of information really for people, and we really should knock at the government's door to give more money for treatment and for preventing maybe diabetes. But how can we prevent? It's again, it's the lack of information for people. People don't know what it is and why should we prevent it, and what does it lead to, and so on. So I think that we should organize more, maybe again, meetings, and we should talk about this, not everywhere, but we should remember that, not maybe remember, but tell other people that we need such help, and there are many people having diabetes and who need this treatment and this access to treatment.
And do you know, Svetlana, and the question is the same for the rest of you, do you know if your association have used a kind of economic study, meaning that proving that if you invest a bit more on diabetes care and access to treatment, you are going to get savings in the years to come? The difficulty here is to prove that you invest money on diabetes, you are going to get savings in 4 or 5 years' time, which sometimes is not that easy to prove. If you talk to politicians that you are going to have some savings in 10 years' time, they are not really interested because they are done with the position that they have in the minister. But Svetlana, do you know if your association have used any kind of economical studies?
Yes, we used such kinds of economic studies, but I think that our government is interested more in some other subjects, maybe such as politics situation in Ukraine and the war, and they are not interested in treatment or preventing some diseases, I think, in that way, because it's not the only bad situation with the diabetes, with other with other aspects it's difficult too. So with healthcare system, it's not too easy here.
Okay, thank you. Kaisa, do you want to step in? And then Luca?
Well, I think that as far as the Swedish Association, we often refer to studies, and we're good at referring. Recently, there was a study on insulin pump, or a few years ago, showing that it improved both quality of life and HbA1c, et cetera, et cetera. And as somebody who knows about the situation, you understand that typically means that the costs are lower in the long term. But we're not very good at actually referring to economic studies to show black and white that this is what happens if you invest here and now in something. So that we can definitely improve in regards to that. But I think as well that your question, Jay, on what we can do as advocates, I think that one of the most powerful tools that we have are our personal stories, and that we shouldn't be afraid to play on emotions and to be emotional. And it's one thing to talk about how many people are affected by diabetes or the cost, et cetera, but oftentimes the things that people will remember are the emotions that you convey and what they feel from hearing you speak in your personal story. And I think a lot of times we underestimate the power of that. And thinking about something like diabetes, oftentimes where you see action is when somebody is personally affected by the disease, and it's the same thing for politics. A lot of times the questions or the issues that are debated are the ones that people are personally affected by, and I think we should really utilize that and not be afraid to play on people's emotions and use champions that are affected by diabetes, of course.
Definitely, truly agree. Luca, is there anything else to have?
Well, in Italy, as I said before, we have a really good situation that our national association, one of the Italian national association, as we have like 6, 7 national associations, is working and collaborating with the government so as to develop a law in order to educate the teacher for schools, the teacher schools, so has to have prepared people in the schools ready to do insulin, test strips, or for emergency situation. But this is one thing. Another is talking about changing the balance between money spent for treatment and money spent for complication. Moreover, when we talk about politicians, we have to keep in mind that there is a difference between government and parliamentarians. Usually, when you, at least in Italy, but I think that it's more or less the same in all the other European countries, when you want to have something, to push for something, usually you rely with parliamentarians. And it's a huge difference because you have more than 200 parliamentarians, each one fighting for a specific cause or just to take money for the specific and high wage, but this is another point. The main problem is that when you want to really create a law or change the system, you should have a strong collaboration or a link to a governative person. So a ministry of something, or someone of the technical, the bureaucracy part of a minister. That's because a parliamentarian can really, you say, support your project, the rule that you are promoting or that you're asking for. And maybe they have diabetes, so they are you say on fourth line, ready to do something, and it can really help when it's about changing something, but changing the balance between the expenditures when we are talking about billions or millions, depending by the country, of course. It's another matter, and the top high politicians are not ready to change this balance because it's gonna cost a lot, and it's not gonna have a positive feedback in terms of election. At least not until we, as people from one country, so each country has to think about himself from this specific perspective. So the point is that the national association should try to make the top high politician to understand that, of course, in the short term, they will not have, you say, more points, more votes for the election, because the results are going to be seen in the past, in the future 10, 15, 20 years. So probably there will not be any more politician at that time, for joking. But probably we should try to push more by another perspective, which is we are 6 millions, 5 millions, whatever, in this country. We have daughters, we have parents, we have partners, we have friends. It's a kind of lobby, of course. The aim is we are a really great number of people that are able to vote, and so it is really theoretical and difficult and complex to do, but at the same time, I think that virtually is probably the best and probably the only solution to fix the imbalance between the expenditures. Sorry if I spoke much.
No, it's okay, no problem. Yeah, but it's it's a good question. How can we change that the actual situation? Even if you have there is problems in every single country in Europe. You might have a better access to care or treatment. You might have difficulties in getting insulin, which is the case in some countries in the eastern parts of Europe. But we need to show somehow, we need to use our power, that is the power in our hands, because if you look on the data, if you go to a politician, say that 10% of the population have diabetes, and that diabetes is a disease that affects not only that person, but the family as well. If you multiply by the family members, you get a high number of people living with diabetes in each country. So, and this is sometimes a very good argument when you talk to a politician, saying that, meaning if you do something good for diabetes, you will be, let's say, well seen by this part of the population, which is roughly 10% or so. So it depends, from my experience, it depends a lot in the country. What works best in one country might not be the best in another country, because even not looking at your 4 countries, meaning UK, Italy, Sweden, and Ukraine, the culture is so different. The way people see problems is so different, and I'm talking about the politicians, that we need to use the same arguments when you talk to a politician. Okay, so maybe in Italy, if you go to the door of the politicians and do a demonstration, it will make some sense. But that, I think, in Ukraine does not work that well in that regards. So it depends on the country itself. And Dimitri was putting some question as well, which is linked with NCDs. And there's a huge debate, NCDs versus diabetes. What is the balance, the right balance? If you push forward too much, if you put too much focus on NCDs, are we losing the focus on diabetes? Yes or no? Or should we use, because the health determinants are the same for all NCDs? And this was linked with Luca was saying as well. We need to put more money on prevention. That's essential. And prevention is not only about primary prevention, which is linked with NCDs, but also tertiary prevention of complications, which is a huge part of the healthcare expenditure on diabetes. Yeah, but do you have any action that you would like to share with us, Jay, as well? And there are people that are on the call as well.
So a couple of comments on what's already been said. You know, one point was made about, you know, targeting at the top level of layer of politicians. In this country, the top politician in the country knows quite a bit about type 1 diabetes because she has it. You know, Theresa May, she has type 1 diabetes herself, but has done very little for the community in terms of, you know, furthering the cause of type 1 diabetes in the UK. So, you know, it's a classic example of someone who has knowledge, but not yet the ability to affect the change which the community needs to see. And actually, the most change that we've seen in the last year around diabetes, particularly type 1 diabetes in this country, has come from Diabetes UK working to get Freestyle Libre onto prescription, which, yeah, again, is being applied non-uniformly across the country. My other comment is a conversation that you and I have had a few times.
I think we are losing you, Jay.
Okay.
We can't hear you, Jay.
No. Okay. The connection was very good, but now I think it falls down.
Have I come back?
Yeah.
I'm back.
Yeah, you're back.
Sorry, I was just saying a conversation we've had before is around people with type 1 diabetes. Are we limited by being grouped together with people with type 2 diabetes and then ending up, people saying there's too much money spent on diabetes, and therefore we're not going to invest in treatment for people with type 1 because of a misunderstanding? And I know, Kaiser, you and I had this conversation when we were together last as well in Austria. So it's a really hard conversation, though. Is there strength in numbers, or are we getting hamstrung by being lumped together with people with large budgets?
Both, I think, for sure. I wanted to say something about the question of grouping the diseases together as NCDs, et cetera, et cetera. I think that whether that's beneficial or not, I think that very much depends, again, like we said several times, on the country, because overall, globally, 70% of all deaths are because of NCDs, but about 2 or 3% of global aid money goes to NCDs. So obviously there's a huge discrepancy. But in a country like Sweden, so globally, and then low and middle income countries, it makes sense to talk about the importance of treating and preventing NCDs. But in a country like Sweden, 90% of all deaths are due to NCDs. We have very few communicable diseases. Most of our healthcare expenditure is spent on NCDs. So for us to group all diseases together, diabetes, cancer, heart, lung, et cetera, even beyond that, it doesn't make as much sense, which is also one of the reasons why we don't have a very strong NCD alliance in Sweden, for example. We have one, but it's not very active because each of us are quite dedicated to our own cause, because we also know that the other NCDs are, and this is a terrible word, but they are our competitors in terms of budgets.
They are.
There are a lot of reasons to collaborate, and we do, but there are also reasons why in a country like Sweden it doesn't work as well to group NCDs together.
But that's different. That's one of the things that was interesting. I do remember a conversation that I had with one of the Belgian people. I don't remember which Belgian association, because they have two, the French one and the other one. So I don't remember which one was, but he was saying to me that when NCD took a higher position on the political agenda, they started to lose the focus on diabetes. So part of the money that was spent, and the politicians claimed that they were doing something for NCDs, which included diabetes, but at the end of the day, they didn't do that much, just saying that, and doing so, they proved that they were spending more money on diabetes as part of NCD, but they stopped spending money on diabetes, partly. So they were complaining about that, because IDF was part of an NCD alliance at European level and the global level as well. So it's also a balance. If you do advocacy work for diabetes, it's also an interesting balance. And I would like to ask you, what is your position? Meaning that on one side you say that diabetes is a condition that you live well with it does not affect you, it's not a barrier to do whatever you want to do, but on the other hand, you say diabetes is it's a disease that kills you somehow. Okay, it's simplistic, but you get it. So how can we use those two sides of the same coin when you are doing advocacy to get more access to care?
I think you just said it, to combine those two, to say that if not treated, diabetes is a deadly disease. It's a very serious disease, and you know, with proper treatment and proper access to medications and to medical technology, it's no longer a deadly disease. It's still a serious disease, but I'm able to live a life that is productive in terms of contributing to society and a happy life, a healthy life, etc., etc. So to me, I think you shouldn't exclude either one, and that often worries me when I see that in advocacy, because that doesn't, you know, neither give a balanced view or, in my opinion, is very effective. I think it's most efficient to mention both sides and to say that, you know, even with proper treatment, diabetes is still sometimes uncontrollable. You can't control everything that happens, but you increase your chances of being healthy and happy by having access to quality healthcare and treatment.
But that's not, you are correct in saying that, but it's not that easy to have both sides of the same coin. Asking for more investment when you say that diabetes, it's a disease that you live a long and proper life and purpose life. So it's I found that difficult sometimes to explain to politicians this different balance between the two sides of the same coin.
Yeah, we in our diabetes service in Brighton, where I live, we talk about not putting patients into a box of just good enough, and a lot of patients live a really fulfilled, happy life with the way in which their diabetes is managed, but are on old technologies and on old, you know, older ways of care. But that's because of a lack of knowledge about what life is like with the technologies and how things can be better. And so there's a tension between improving quality of life versus improving health outcomes, and are the two co-linked? And it comes back to the question around data, because you can improve someone's quality of life significantly through technology, but as a policymaker or as a person running the healthcare system, like myself, you know, you're being told constantly save money, and unfortunately quality of life becomes an indicator that gets pushed to the back.
Yeah.
I think people think that diabetes is not as serious as, for example, cancer is, because people with diabetes can live more than with cancer, maybe, and the politicians, I think, have the same mind about it, and that's why they. I know many people who think that diabetes is not as important or is not as a difficult disease as other illnesses, other diseases.
And this is linked with what Jay was saying as well, and I'd like to have your opinion, because sometimes the politicians just say that, okay, I have too many requests, I have a limited budget, I cannot invest money in all things that people are requesting from me. So why should I invest more money on diabetes and not on other area of healthcare? So what do you see that, and what do you think that it should be your answer to that question?
I think in that scenario, João, you're getting a situation where you're asking politicians to make clinical decisions, and it comes down to a philosophical question almost of, is that the healthcare system that you want to run? You know, recently, I wrote a letter to our local system to say, you've decided not to fund, you told clinicians not to prescribe Freestyle Libre, because it's not on formulary, or because it's not being nationally, so locally used. Well, you're telling a clinician to not prescribe something, which means actually they're not giving someone the best care possible, and so, or the best care that they deem is necessary. And so there's a philosophical argument there over, you know, actually is that politician looking at, you know, undermining the principles that the healthcare system is built upon, and then it comes back to, well, do we remove those politicians that are undermining the principles on which we've built a healthcare system?
Definitely. Luca, do you want to say something? Do you want to say?
No, I just talk about the SPA and UNETA. SPA is a kind of yeah. I don't know, but I was just proposing to see whether there are more opportunities trying to focus more on HTA, which is as a bridge between science and politics. I want to say that UNETA is an European project, a 10-year project with the aim of connecting all the HTA agency in Europe between each other and country to country to have more data, to gather the data from each country and so on. There is a privacy issue about the data, which are, of course, anonymous, but at the same time, no one wants to give their data. So there are some problems, but right now there are already a lot of agencies in each country that are working on this data and this analysis and this evaluation. And so the aim of HTA is to see, considering the compliance of the patient, if he has parents or son or a partner or someone that can help him in the management of a particular situation. It does some evaluation for any specific and possible solution to a specific problem or process or disease. Which one is the best in which situation?
So I have a challenge for you all. One of the things that you can do, one of the things that you can do to solve the problem, or try to solve the problem, is to get into the bodies that are making decisions. Because we have now a huge group of youngsters prone to get decisions on the right direction, very active in all fields. So if we manage to get all of you into this, to making decisions bodies, that will be something that will be quite helpful. So it's a challenge to all of you to, in your future, near future, medium future, not long, hopefully, meaning that getting into decision-making bodies, that will make a difference. Have you considered that? You never consider that. Not ever.
I have a theory.
You can't resist it.
Sorry. No, but then I think the problem is that then all of a sudden you're put in that position and having to prioritize between something that you think is important and something that is perhaps objectively more important. So yeah, maybe in the future. But I do think something. Sorry, Dave, just a quick comment. I do think that's. I mean, this is quite provocative to say, but personally, that's been important for me to educate myself on what is the situation for other diseases as well. Because at times, you know, I think that something is incredibly important, but then I have to take a step back and realize that in Sweden, we have access to free insulin, we have access to test strips, we have this, and that. And in this case, perhaps for everyone to have access to CGM device is not the most important political health question at the moment. And maybe I should take a step back, and maybe this isn't something we should be pushing right now. I think that's, I mean, I understand that's not the case in every country. Obviously, we have a, you know, fairly good system in Sweden, but I think that's important as well to realize and to remember, and that's also hopefully a way to success.
Yeah, Jay, you are a bit putting your that's your shoes. I mean, I think.
Yeah.
No?
Yeah. Me?
Yeah.
No.
You are in a position where you have to make decisions. So.
I'm already. I mean, I am in that situation, right? So I don't disagree with you, João, but one thing I find very difficult is the exact situation that Kaiser just described. You know, as a person with type 1 diabetes, being in that position makes it ever the more hard, because you're almost influenced in a way where other people aren't influenced. You're influenced towards supporting people with diabetes, and that's it. And that's a natural state to be in. And then having to make a decision to say, well, in order to fund this, I'm having to defund this, becomes a much more difficult standpoint. And that becomes really, it's ethically very hard to argue against yourself in that situation. But I always, I find it difficult to ignore a challenge from you, El Presidente. So, I'm gonna do it.
Thank you, Jay.
Let's do a follow-up in 2 years and see where we are.
Yeah, definitely. And well, I would like to follow up with all of you, definitely not in the next 2 years, but in the next 2, 5, 10. Well, 10 is something that I can expect, because my life expectancy is getting less and less and less. But yeah, sure. Well, I would like to thank you, all of you, for this same webinar. Many thanks for the speakers, for the audience, for your input, Jay, as well. And I think it's now time to finish up. Take care. Have a nice week, and I hope to see you very, 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 very soon. Okay. Take care.
Thank you.
Bye.
Thanks, everyone.
Bye. Bye. Thank you.
Thank you.
Thank you.
I think we were not that many, but it was a good discussion.
It was, yes.
Thank you so much. We'll be in touch.
Thank you. Bye. Take care. Bye.
Thank you, everyone. Thank you. Thank you, Dimitris, Kaisa, Caller 5, and everyone. Thanks.
Thank you all.
Yeah, bye-bye.
It was very interesting. Bye.